my little about myself slide. So I'm born and raised here. That is a picture of me and my husband and my mother when we took her to Portugal 2 years ago, I guess. Yeah, for the summer last year. Last year. So my husband is Portuguese. His mom grew up in a small town in Portugal, so we go back almost every year. I am second generation Canadian, so we don't have anywhere cool to go, except for Winnipeg, which is cool. That's my dog. My dog is Molly. She is 3 years of age, so she is our child per se. I graduated with a theater degree, so I was going to be an actress until someone told me I would make no money. And then I went into medicine and did medicine P's at U of M, and then I did my endocrinology in McGill in Montreal, spent 3 years there. And now I'm a 50-50, or what they call a 50-50 split, which means 50% of my time I am a physician taking care of the kids, and 50% of the time I am a researcher researching how to care for the kids. Outside of that, I like to run and cross-country ski in the winter, and I didn't change this from last year, so now I'm an intermediate tweeter. I'm not a good tweeter. I'm still not an excellent tweeter. All right, we're going to talk a little bit about a cat. So cats, I was given this topic because we actually do it in pediatric endocrinology. So if you spend a 2-week rotation with us, we expect you to do a cat. A month rotation, you do a project. A cat is a standardized summary of evidence. So it is a sort of grouping of all of the available evidence on the plus side and on the negative side, and then your own assessment about how it helps you answer a clinical question. So it addresses a very specific question, so that's specific to a cat. It's not, in general, how do you treat hypothyroidism? That might be a review or a textbook. It is in this child with this disorder at this time, given these caveats, how should I do X, Y, or Z. And it's a statement of the clinical relevance of the results, because probably, and you will find this if you haven't already, that there isn't going to be a paper that's in this 3-year-old who has ADHD and also short stature on chronic asthma medications, who is only growing this much, with a mom and dad who are 5'7" and 6, right? Nothing's going to match your kid exactly. So you got to give and take a little bit and find what you can that closely matches the question at hand or the child at hand, so that you can provide the best medicine. So that's what a CAT is. It's not Journal Club. So Journal Club really is, if you were me as a resident, the night before you Google endocrinology and pediatrics, and then there's a New England article and you say that's a good one to do, and then you read it and you critique it. So journal clubs are really meant to look at one paper that's come out recently that everyone's talking about, the LIFE trial, the LEADER trial, the this trial, the that trial, and then you sit down as a group and say, well, what did that tell us, or how could that inform our practice? Critically appraised topic, instead of it being based on this new paper that came out, it's based on this new kid in your office. Okay, so that's kind of the difference. It's not a systematic review. A systematic review is much more detailed, and it goes much more in depth into the literature than a critically appraised topic does. And it's not abstract summaries. So an abstract summary is this was the group of people, this was the methods, this was the results, without any critical thought put into whether or not those methods are appropriate, whether or not those results or those conclusions are substantiated based on the study that they did. So that's why it's not those three things, okay? So a systematic review, the problem with that is that it needs specialty teams, right? So the question of a systematic review is the PICO question you guys will be used to. So, population, intervention, comparator, control, and outcome. You need to find the best evidence, but you look at multiple studies, right? And so they look into the gray literature. They write the people who wrote that paper to ask for their actual database that they got their results from. It's very in-depth. Usually 2 people appraise the paper, so it's not just me reading 10 articles and then writing what I think. I do it, James does it, Duncan does it, and then we sit around the table and we compare different angles to it and how we found those articles. And then we grade sort of their outcome, and we synthesize the results. So we look across 12 papers and say, are they close enough in what they measure? Are they close enough in the exposure and close enough in the outcome that we can pool all of these kids and pretend they did one study with 500 kids instead of 5 studies with 100 kids? So that's what a systematic review means to do. But because of that, it takes a whole team, it takes 6 months to a year, you're looking at thousands of articles, and the patient that saw you that needs immediate management is not going to make it that long, right? But if we do just an evidence-based review or a CAT, we're asking the same question. We're looking for the best evidence. So now we're not going to look at 2,000 articles. We're going to pull up articles that are the most relevant because we're going to be really specific in our search. We're just going to search for the age range we want, for the problem we want, for the outcome we want. And we will look through those cursory and say, do we have randomized trials? Do we have systematic reviews? What's the highest level of evidence I can pull up? And then I'm going to pull out those 4 papers, the 4 best papers, right? I'm not going to read all 2,000 of them. Then I'll appraise those 4 best papers and see if they're appropriate, and then I'll apply the results I get from those papers to my patients. That takes me, so 120 seconds might be a little bit of a undercall, let's say a couple of days, right? You see the kid on Friday, you go home for the weekend, you do a little search. By Monday, you have a good idea of either what test you should order or what drug you should order, and you're looking at maybe maybe there is only 1 article, that actually fits the question you're asking. Maybe there's 10. Jesse, I'm sure glad I didn't put your cat up here. I used one as an example. Yours was excellent, but that would have been embarrassing. You would have been like, hey, I wrote that. So you're gonna look for the best evidence, and then you're gonna appraise it, okay? So CATs basically are broken down into 3 major stages. Ask is what's the question you want to ask. And like I said, as opposed to a journal club or a systematic review that asks maybe a broader question to capture all of the literature, we're going to ask a very focused, specific question about our kid as best as we can. But we're still going to do it in the PICO format because that's the best way to develop a search where you're going to actually get some reasonable output from whatever search engine you use. So most of you will be used to PubMed, and that's how I trained. I use Ovid now. I'll tell you, I think that maybe they're starting to train people in Ovid because it includes PubMed and Embase and Cochrane. So it's like PubMed on steroids, if you will. So Ovid is a pretty good one to use. And then the Cochrane database will get pulled into that if you pick it. Otherwise, you can look through the Cochrane database itself. The Cochrane database is sort of what we would call the top of systematic reviews, right? So it's a very lengthy process, multiple people involved. They look at all of the literature, but essentially they come up with systematic reviews. They don't do original research through the Cochrane database. And then you're going to decide on the 3 papers that you pick whether or not they have internal validity. So whether or not the paper you're reading makes sense in terms of its conclusions and outcomes. And that's mostly based on bias, right? So internal validity equals how much bias you have in any given study. And bias comes from not being blinded, not being randomized. So all of the things that make a certain study better than another study, all those things are based on internal validity, and internal validity is based on reducing bias. Make sense? So the first thing we're going to do is ask a clinically relevant question. So it sounds like I'm beating this up, but it's actually the most important part of a CAT, because otherwise you're going to try and do one of these and get 500 articles and be way too overwhelmed with your search. So these are usually for CATs foreground questions because we're interested in something to do with this child right now. So what is the patient's problem? Asthma. What is the main intervention? Humidifiers. What is the comparison intervention? There isn't one. I just want to know if humidifiers are better than how he sleeps normally. What is the outcome of interest? Reduced wheezing days. Okay? But that's a very specific search. So when you go, it'll be in children. Are we talking about adolescents who have asthma? Are we talking about 2-year-olds who have bronchospasm and asthma? Because maybe they respond very differently to dehumidification, right? So in children, you can say 3 if your kid is 3, but you might get no hits. So you might have to say in toddlers, in preschool children, in children age 1 to whatever, right? Who have asthma or asthma and wheeze, if you don't get anything, does, right, a humidifier improve days of wheezing? Okay. Then we need to search. So there's 2 different sources. They're what they call sources of literature. The secondary sources are sources of literature that are above our base sources. So our base sources are just publications. Base sources are what we're used to. It's that paper in Pediatrics, Journal of Pediatrics. It's the paper in the New England Journal of Medicine. Secondary sources are sources that try and combine those pieces of evidence together. So PubMed has something called clinical queries, which is basically the same as a Cochrane library review. So if you've read a Cochrane review, you sort of know how these work, but they're either meta-analysis or systematic analysis, and they're often analyses of multiple of those. So you have 3 people who have done a meta-analysis and 2 systematic reviews. They'll analyze those together. So those are translating research into practice is TRIP. NICE is the National Institute on Clinical Excellence, and then the National Guideline Clearinghouse. So all of those have big reviews where someone has done 100 cats for you already. And if you can find one of these, then all you really have to do is make sure it's appropriate and that it fits your patient question, patient population. Primary sources, if you can't find, because obviously that doesn't answer all the questions, then you go to your primary sources, which are the ones we just talked about. The Institute of Science Web of Knowledge is another one of those search engines that you can use to look for articles. When you look at secondary sources like systematic reviews and Cochrane reviews, the important thing is to see how they combine those things together. They don't tell you what each individual study necessarily has done, but they'll tell you heterogeneity. Are the studies the same? Are they different? Are they different on important things like our exposure? Can someone actually lump all these studies together? Does it make sense to do so? And when you look at primary studies, it's just one study. So it's all the things you're used to in terms of ABM. Okay? So in terms of level of evidence, this isn't probably going to be all that new to you, but just as a review, these are all based on limiting bias, right? So a systematic review of RCTs is probably the number 1 because it's a whole bunch of RCTs that used to be the best evidence, and they've taken those and put them together so that you have 3 times the N, right? Like you've maxed out your sample size, and as long as it's appropriate to do so, and those 3 studies all actually look at the same thing, then that's probably the highest level of evidence because it has the highest amount of power to detect an effect size. And RCT then is probably your next highest level of evidence because it's randomized. So it gets rid of bias from confounders, right? Known and unknown. And that's usually RCTs then that are double-blinded. So it gets rid of investigator bias, it gets rid of patient bias, because nobody actually knows what's going on in the study until the study's over, right? Systematic reviews of cohort studies comes next. So systematic reviews are always sort of the one level higher than the study itself. And then cohort studies. The reason why cohort studies aren't as high, obviously, is because they're not randomized, they're usually not blinded, and so all of the different bias comes in. Same for cohort studies and case control studies, which may be controls that are historical, controls that aren't exactly your population, right? So the more you add in different variances in what you're studying, the more bias you might get. Okay. So how do we appraise it? Well, there's a general appraisal and then there's a specific appraisal. So now we found our papers and we're going to look at one and say, is this appropriate for me to bother reading? Because I don't have that much time. So did the study address a clearly focused issue? And is it my issue? If it's not, we toss it. We don't have time to read a whole bunch of studies. Then you should really look to see if the methods make sense. Because if the methods make sense, then read the results. If the methods don't make sense, it doesn't matter that their effect size is that this causes 200% less asthma exacerbations. Because if they weren't, right? Because if the study itself doesn't make sense, then the results are garbage and you throw that out. So the first thing to do is say, does it match my PICO? Does it make sense for me to read this? And then, is it good science so that I can read the whole thing? Because sometimes if you read a paper and it's not good science, but the results are fantastic and the curves are crazy, you tend to want to read that paper and believe it because it looks so good in the results. So I would suggest not even to move on to that and focus a little bit on the methods, right? So do they have a reasonable, are they powered to detect a difference that's, at least clinically significant? So sometimes I'll read papers or research proposals that'll come past my desk for granting agencies, and they'll have done a power calculation so the most recent one I looked at was to detect a difference in neonatal adiposity of 5%. I don't know what that means. So if I give you $1 million and we detect a difference in neonatal adiposity of 5%, is that relevant to anything? Like, I don't know if that changes their risk of diabetes. I don't know if it changes the risk of, right? So I think sometimes you have to read these things and say, so they're powered to something, but is it a reasonable something? Is the design appropriate to the stated aims? So if it's an intervention in an observational study with no control group, that's not appropriate, right? You need some kind of comparator, and best to have some form of randomization in those studies. And all of those things will tell you whether or not this is likely to be a valid paper and to whether or not you should bother reading it. They should tell you what the statistical methods are. You don't always have to know if they're appropriate, and sometimes I'll get a paper that I'm supposed to review and I'll say, ask a statistician. I don't know if this is appropriate. I don't have a master's in stats, right? But you need to, at least they should disclose what they are, and they should kind of seem like they make sense, okay? And then, do they have any significant untoward effects? So if the effect size is really great and 3 kids died, you can probably toss that paper too, right? Because chances are you're not going to use it, even though it worked in the other 8. And then specific appraisal is, how much do they tell you about each of the little areas now? How much do they tell you about baseline characteristics of the kids so that you know that the control population and the experimental population are the same? Do the numbers add up? So every once in a while you'll read something and they say, we had 5,685 kids, and at the end table, you'll see an N of like 266, 80%. And you're like, well, how does that, somewhere they should have told you where the rest of the 4,000 kids fell out of the study, right? Is it significant? So remember, p-value won't tell you anything about the effect size, and it actually also doesn't tell you whether or not this is a true effect of whatever you're studying or it's chance. It just tells you that it's different, and the likelihood of it being chance is less if it's over 0.05, right? And then what do the findings mean? Are important effects overlooked? And what does this say about my patient that I'm going to see in clinic on Monday? Okay. So the first step to appraising is just to match what we look for in a paper to our question, to look at internal validity. So that's going to be all study design, right? The next step is to say, is it generalizable? If you have a paper that doesn't have internal validity, guys, then it's not generalizable, period, right? You can't be like, well, this paper sucks because they really didn't measure the proper exposure or outcomes, but it appears to be generalizable because they had a nice cross-section of kids. It's not, there's nothing to generalize because you don't have a reasonable answer to the paper. So that's why don't bother looking at the generalizability, and I wouldn't even report on generalizability. If it's not valid, you should just throw the paper out. And then whether or not the results are actually clinically relevant. So there's going to be some papers that are, you get an effect size and they're statistically important, but clinically relevant. That happens a lot in obesity paper, right? So kids will lose a certain proportion and and it's, -1 standard deviation, and it's statistically significant, but whether or not it's clinically relevant is hard to say, unless there's long-term follow-up studies that can tell you that. Okay. So if you're looking at therapy papers, right, then the best thing is a randomized controlled trial, placebo, double-blinded. And so that's basically what this slide is just going over. Check, 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 right? And that tells you whether or not this is an optimally designed. It can't always be that way. You can't have a blinded trial of an insulin pump. I suppose you could. I suppose you could put saline in one. They don't, though, right? So there are certain things that if a kid's going to see it, right, or a kid's going to know it. And so there are some things that you can't do. So be forgiving. I mean, otherwise you'll toss out every paper you read and then you'll come with no cat. But this is sort of the top, and then you got to give or take, right, a little bit with what's reasonable. And so kids should have things like the same-ish baseline characteristics. Don't compare 5-year-olds to 15-year-olds if all the 5-year-olds are in the experimental group and the 15-year-olds are, right, in the comparator group. So that's pre-intervention similarity. Are the kids kind of the same? Are they all from Winnipeg? Am I comparing kids with type 2 diabetes from Garden Hill to kids from White Ridge who are Caucasian? Because that's not a fair comparison, right? So those sorts of things. And then valid measures of treatment effects, which we're going to go over. Sample size is always important. So if a tool hasn't driven sample sizes into you, by now you will get those driven into you by the time you're done your resident research project. Those are just super important. I think because it's such a waste of time and money to do a study if it's not powered to know anything. There's really no point, right? And then is it statistically significant and clinically significant? Knowing those aren't the same thing, right? Just because something's statistically significant doesn't mean it has any clinical importance or relevance. Confidence intervals tell you precision, right? So the confidence interval, do you guys remember what that is? Yeah, so it's whether or not your estimate. So if you say 5% of children who eat M&Ms will have diabetes by age 10. That's not true, so don't remember that. This is just made that up. But let's say that happens, right? And the confidence interval is 2 to 10. What it means is 5% is what I get from this group of kids, because I've studied you guys, so whatever, you all eat M&Ms, I don't know how many you are, 12. But if I said, but really, in Manitoba, is it 5%? I'd say no. In Manitoba, it might be 2%, and it might be as high as 8%. So the real value lies somewhere in this sort of cushion. And because I didn't study all of Manitoba, and I only studied these 12 people, I'm saying 6 because that's what I got out of here, okay? So that's what confidence intervals tell us. So if our confidence interval is 0 to 400, right? Well, no, actually anywhere it could be from no kids get diabetes to, 400% of them do. You can't get 400%. That's probably not a good study either, right? It doesn't really tell you much, even though I'm telling you it's 6%. If the confidence intervals are this big, it's probably not a very good study. Okay, these are stats. Any questions before we get to stats? I understand that Eleanor Simons is going to go through a lot of stats with you, and so I'm allowed to briefly overview these stats so that we're not late. Have you seen the stats yet or no? Has Eleanor come? You did it. Okay. So these should be a bit of a review. So treatment statistics and diagnostic statistics and prognostic statistics are all different, right? It took me a long time to figure that out. I just used to memorize them all. And then I realized that you have to put them in little boxes depending on what you're reading. So if you look at treatment statistics, these are the stats. So if the article is meant to look at whether or not a treatment works, then there are things like relative risks, right? So what is the risk of this happening in an exposed group versus the risk of this happening in an unexposed group, okay? The absolute risk reduction is just really the absolute difference in the proportions that experience your outcome in each of those groups. Okay? Does that make sense? Yeah? Okay. And number needed to treat is how many kids do I have to treat for one kid to get better on this treatment? And then number needed to harm is really the opposite of that. Okay? Yeah, good. Can I go on? Yeah. Okay, diagnostic, so that is treatment. Diagnostic papers. So now we're gonna read a paper about a diagnostic test. Should I test my kid for this? Okay. When we look at diagnostic tests, we're talking about how accurate is the test and how precise is the test. Those are the two big headings of diagnostic papers, okay? Accuracy is the amount of agreement between the indicator and a reference standard, okay? So let's say we're talking about, so I'm clearly on call because all I can think of is diabetes stuff. But let's say we're talking about a continuous glucose monitor, and we say, how good is a continuous glucose monitor in a kid? Can they use the numbers that are displayed on their belly instead of finger pokes? Well, I need to know if it's as good as the finger poke, right? You can't just replace it. So accuracy would be, if I do the reference standard, the gold standard might be blood draw, right? But if I do the reference standard, right now kids are using a finger poke to make decisions. If I use the reference standard finger poke and I compare it at the same time to the CGM, how close are those two numbers, okay? How accurate are those two numbers? And so they would measure the, well, it's not the diagnostic, but I guess it would be the blood sugar accuracy of my CGM machine, right? The stats for that are positive and negative likelihood ratios. So I'll show you that in a minute. Precision is exactly what we talked about. What is the window of truth around that accuracy? So my CGM is 98% accurate, plus or minus 45%, right? Maybe not that accurate then. What you're saying is it's accurate anywhere between 20% of the time and 99% of the time. But on average, 50 or 60% of the time. So it's important what the precision is, right? And you calculate that by the plus or minus of the standard error, right? Okay. It depends on sample size and reliability. Does that make sense to you guys? If you have 10 kids, their variability is more variable than if you have 100 kids, where all of their noise settles down just because you have more of them. Does that make sense? Yeah, okay. Okay, so diagnostic statistics. You know sensitivity and specificity then. That, I'm sure, has been drilled into you. The positive predictive value and the negative predictive value is how good is a test at predicting the disease. If it's positive, does the person actually have the disease? If it's negative, does the person actually not have the disease? The issue with positive and negative predictive values is that they are somewhat based on what the disease rates are in your population, right? So that if only 2 out of 1 million people have this very, very, very rare disease, it's going to impact whether or not if you have a positive predictive value, it's actually positive, right? Or if you have a negative test, it's actually negative. If you have a really, really, really common disease, same thing. A likelihood ratio, on the other hand, because it's just sensitivity and specificity and it's not positive and negative predictive values, which are true positives and true negatives in a population that you studied, because this is based on sensitivity and specificity, it actually should be able to be applied to any population. So it doesn't matter that we have 20 times the rates of type 2 diabetes than Calgary. If we have a test to test for type 2 diabetes in kids and we use likelihood ratios, it should work as well in Manitoba as it does in Calgary. Does that make sense? Yeah? Okay. So these are the nomograms. So you can do the math or they have nomograms, right? So the pre-test probability, so by percent, so it's a 50-50 chance, let's say, before the test that the person has diabetes. And then we do the test and the likelihood ratio is really good, so it's above 1, and let's say it's really great, so it's 10, that's a pretty strong test. So we do 50%, but then they're positive on the test, which is 10, so they actually, the post-test probability is somewhere about 85, we're 85% sure that kid actually has it. That's how good this test is, with a likelihood ratio of 10. That's how you use the nomogram. Make sense? Yeah, okay. All right. So a positive likelihood ratio is our confidence that a positive test happens in a person who has the disease. So just like I said, the higher the likelihood ratio, the better the test is. I picked 10 and above tends to be where we say this is a great test. Okay, so 10 is high. A likelihood ratio of 1 is a flip of the coin. Okay. And then a negative likelihood ratio is just the opposite. So it's the degree of confidence that a person with a negative test actually doesn't have the disease. So we're not missing someone. And in that perspective, the lower the likelihood ratio, the better the test, right? To rule out a disorder. So we want to drop down into the negatives. Okay, good. I hate flipping it if people are typing. So are we good? Yeah? Move along? Okay. Okay. What if we are going to look at the secondary sources of information? So that's all primary. I just talked to you about your PubMed search, right? So now we've moved the PubMed search, and now we're going to look at Cochrane reviews, systematic reviews, meta-analysis, all of the secondary types of information. We still have to match our question. No point in reading literature that doesn't actually help us, help the kids we're looking at, right? But there's a different way to appraise systematic reviews, right? So if I did a systematic review, theoretically, I could pick whatever papers I want to put into the review. I really think that if we give every single kid in the province an insulin pump, everybody's A1Cs would be 7%. So maybe I'll just only grab all of the papers that say that pumps lower your A1C. There's probably some papers that say they don't, but those papers probably aren't great anyway. Clearly you're not allowed to do that, and so that's why it says, did they look at all of the literature? So did they look at the stuff, is it just a PubMed search? Because it shouldn't be. It should be PubMed, it should be Ovid, it should be the gray literature, it should be abstracts, right? So if you go and you use Ovid, it actually pulls MBase abstracts. So if I present an abstract at CDA, that will be pulled in if you have the right questions, okay? So all of the literature. And if I threw out studies, yeah, I found 20 studies, but I threw out these 10. Why did I throw them out, right? Is that reasonable? Were they just really bad studies? Because that's fair. Are they studies on 75-year-old men? Because, okay, I get it. You're trying to do a pediatric review. But if not, then the question is, how come that paper didn't make the cut, right? So that's a way of you sort of reviewing the bias of the people who are doing these systematic reviews. Most of the time, those things, if you get a systematic review published, actually have to follow an outline. So there are guidelines, Concord guidelines and other guidelines for these things that you have to submit with your publication. So someone who is a publisher should have done some of this for you, but it's always a good thing to just review on your own. Heterogeneity of studies is exactly that. You can't mix apples and oranges and throw them in a basket and count them. So you have to know that the outcomes are the same outcomes, at least roughly, and that the exposures are the same exposures, at least roughly, right? So you can't pool studies that can't be pooled, basically. And then what do the pooled results tell you? And then look at the, am I doing this right? Yeah. And then look at the summary of results. So this CEBM, Clinical Evidence-Based Medicine, I think is what CEBM stands for. It has a whole bunch of different things. It has a whole bunch of templates for your journal clubs. It has a whole bunch of other things. It's a really good website. But it also has a cat maker, which is this here. And it actually feeds you through it. What was your question? What was their design? How many kids? And it helps you also, it will help you build your question. So if you say, well, this is it, it will put it into a Pico for you. And then you summarize the results in a CAT. So you say, this is how it matches my question for my kid. This is the highest level of evidence I could find, these two systematic reviews in a randomized control trial. And these two have the best internal validity, and so I've read them, interpreted them, and this is why I think we should do this with Johnny. Okay. Presentation of the results. This is just one example. This is what we use in our clinic. So the clinical question, and then the bottom line, search strategy, how did you find those papers? The evidence based on the studies that you read, the results, and then quality issues are, what is your critique? You know, what are the limitations? Every study has a limitation, okay? All right, let's run through this quickly. Was this one you did? No. Okay, so a 3-year-old boy with classic CAH followed by the pediatric endocrine clinic. So it was a resident. One of our residents did this. And this is an actual case, right? So the kid was on hydrocortisone and fludrocortisone as you treat CAH. And mom came in and said the visit prior, he had this severe hypoglycemic episode and he seized. And so we did a whole bunch of other workup, and he didn't seem to have any other diseases, and he wasn't sick, and he didn't have liver failure, and there was no other reason for him to be hypoglycemic. And so the thought was, well, he just doesn't have enough cortisol replacement, right? Cortisol is a counter-regulatory hormone, and without it, you can go hypoglycemic and seize. So they bumped up his doses across the board. Now, I'll tell you that a normal dose is somewhere between 8 and 12 milligrams per meter squared per day, and a fairly significantly high dose would be 20 milligrams per meter squared per day, and we knocked this kid up to 17.8. So he comes in 3 months later and we look at his 6-month growth, and he's stagnating on his growth chart. He might be stagnating because he's a 3-year-old boy and they have fits and spurts, and he might be stagnating because we have just upped his dose of hydrocortisone and now he's suffering effects of growth suppression because we've upped his meds, right? So the question is, well, what is the evidence that putting him on this dose of hydrocortisone will suppress his growth, right? To what extent does hydrocortisone dosing affect the growth of children with CAH? Or the peak it would actually be in children of whatever, toddler age or school age children. What does increasing hydrocortisone dose do to the growth trajectory, right? So we looked at adrenal hyperplasia, congenital adrenal hyperplasia, congenital adrenal hyperplasia and drug therapy, and growth in these, and came up with this paper, Impact of Hydrocortisone on Adult Height in Congenital Adrenal Hyperplasia, the Minnesota cohort, which is a pediatric cohort. And so this is, we're not going to go through this whole thing, but this is what it looks like when she presented it to us. So this is what a CAT can look like, right? Clinical bottom line is, after I read this paper, what do I think? And she thinks hydrocortisone is negatively associated with predicted adult height, and by each 1 milligram per meter squared per day increase in a dose, it's associated with a 0.37 centimeter decrease in the predicted adult height. So every 1 milligram per meter squared we go up, their height drops. Even with the recommended hydrocortisone dose guidelines of 10 to 15 milligrams per meter squared per day, there is still some negative effect on height. So we're outside of the recommended dosage because this kid was having lows, but even within that narrow range, there's some difference in how kids grow, right? So here's the case that we just went over. The case scenario, the clinical question, the search, and then this is how she did it. So here is the study, a little bit about the background, what we normally give kids with CAH. So there's a place to start. Okay, what's the guidelines? What should I be doing? Because that's where we start every time we treat someone, right? What's the guidelines? And then what does this study look like? And what's the type of study? How many patients do they have? Is the study powered enough? What kind of stats did they do? Are they appropriate stats, right? So all of that is what she looked at. And then what were the results? So what did they find? Here's the slope of increasing hydrocortisone and decreasing height or growth attainment over time. And then there's a section on comments and limitations. So here's what she found. The fludrocortisone doesn't seem to impact growth. The hydrocortisone does. And so the more you can up their fludrocortisone, the less you need to put them on hydrocortisone, right? Higher doses in the first 2 years of life don't seem to impact. So when they're little, and we're first trying to get them under control, they seem to have enough time after that to have catch-up growth. And then the study acknowledges the need to consider other factors like timing and frequency of hydrocortisone, individual pharmacodynamics in terms of the need for cortisol, pharmacokinetics in each kid. So this is where the limitations are. Your kid might respond differently than other kids, right? But as a whole, in kids about the same population with exactly the same disease being treated with roughly the same medications, this is what has happened in this population. And we could debate whether Minnesotan kids and Manitoban kids are similar, but I suspect they're somewhat similar. Okay, so let's go through a case of BW. So this is our little practice. And then, does anyone recognize these guys? Yes, you're not that old. One or two. I grew up to this. This is a Fraggle Rock kid. So BW is a 10-year-old girl brought to endocrine clinic for assessment of short stature. She otherwise has no significant past medical history. She has no symptoms or signs consistent with hypothyroidism, cortisol excess or malabsorption, and GI distress. So when you come through our clinic and you go, this is one of the consults you are guaranteed to see, because we always see kids with short stature, right? And she's gaining weight. So she seems to be an otherwise healthy kid who's short, okay? Clinical assessment says she's Tanner stage 2 puberty, so that makes sense. It's early puberty. She's 10. Her bone age is the same as her chronological age, so her bone age is 10. She seems to be doing what she's supposed to be doing. And I say to James, what should we do with this kid today? James looks through all the blood work and he says, well, we've done a CBC and electrolytes, we've done the renal function test because the kid comes from Marnie Hanna and she's brilliant. She already did everything we need to do. Thyroid function tests are normal, Brandy. The only thing that they didn't do on this kid is a celiac screen, right? The kid was poked last week because we got him in as an urgent consult even though it's not an urgent consult. The kid was poked last week, okay? So the only thing we didn't do is a celiac screen. And the kid's so cute. Look at how cute this kid is. So then James says, Brandy, we're gonna have to repoke this kid. This kid's only 10, afraid of needles, so cute. Do we really need to poke the kid to screen for the celiac test? And I say, that's a very good question. As all of your preceptors and staff will do on rounds, that's a very good question, meaning we don't know the evidence for that. Why don't you go and read that, and then we will discuss it when you come back. So that is the general response, because we don't remember everything. You won't either. And so James says, okay, so what I need to do is figure out the answer to this question. The easiest and quickest way to do it is a cat. And then if you do this cat, you can stick it. And I don't think you have a cat resident place, but I really think you should. Because if each one of you does this on some rotation for something, they're not good forever, right? So what the limitations of a cat are in 2 years is obsolete knowledge. That's the benefit of always having new knowledge, is someone will have to do a new cat because there's a new medication. But at least for probably a year and sometimes 2 years for some of these diseases, the cat's going to be good. And if you have a bank of them, someone else will come through with the exact same question, and I'll have forgotten James's brilliant cat because I'm a year older, and I'll say, I don't know, why don't you go and read it? And then you'll just pull up James's cat, put your name on it, and come back and look brilliant. Don't do that. But you know what I mean? Like, you can share this. You're a group of people, and so learning can be shared. So I would say you should bank these. But here's the question. Children with short stature and no gastrointestinal symptoms, right? So we're talking about an otherwise completely healthy kid who's short. What is the utility of doing a celiac screen, right? So that some of that is going to be the basis of what is the prevalence of celiac disease in our pediatric population in Manitoba. Like, if nobody has it, the chances of us needing to do a celiac screen when like 0.0001% of kids actually have celiacs is probably negligible. And And then what is the utility to diagnose the etiology of short stature? How many kids would be missed with this being the basis of the short stature if we decided not to do this blood test on any of them, right? So if you look, when I did the PubMed search, if I do PubMed, Embase, and Cochrane, which is basically Ovid, those are just the sub ones that I picked, I get 233 results, but I'm not about to read 233 papers over my weekend. Neither are you, I suspect. And so I say, okay, let's do short stature or just short, and height or failure to thrive or dwarfism and celiac disease. Sorry, that's all of them. And then I say, okay, let's limit it to children. Let's limit it to English. Let's limit it to last 5 years. 24 results. I'm not going to read 24 full papers either, right? This is when you get 2 pages of the abstract and you just go, not applicable, not applicable, not applicable, not applicable, this one I should look at, not applicable, not applicable, this one I should look at. So then you get maybe 5, right? So here are some of them. Low incidence of pathology detection and high cost of screening in the evaluation of asymptomatic short children, for which celiac disease is one of the screens. Does every short stature child need screening for celiac disease? There's another. That sounds like an appropriate, but let's pull that one, right? Seems appropriate. Short stature and the probability of celiac disease in the absence of gastrointestinal symptoms. That also seems like a good one. And then routine measures of gluten antibody in children of short stature. So now I've got 4 papers. They all seem reasonably good. I don't have a Cochrane review. No one's done this as a Cochrane review or a big meta-analysis, so I'm going to have to pull these 4 papers, but I can take a look at their findings in each of them. So I take a look at them and then I do my CAT. So the clinical bottom line, based on reading these papers and looking at the best internal evidence of them, or internal validity, which happened to be this Archives of Diseases in Childhood 1, short stature and the probability of celiac disease in the absence of gastrointestinal symptoms. 1, it matched our cohort exactly with the absence of gastrointestinal symptoms. The others didn't. And 2, they had very clearly powered their study to look at this question, and they had very clear outcomes and very clear testing. And they didn't mix a whole bunch of, well, we'll do it by antibodies plus by scopes, plus we'll do it by symptoms and we'll call them truly celiac, right? They had gold standard in terms of testing. So when you read it, 1.8 to 6% of kids with short stature who had no GI symptoms the other thing was, this wasn't just a subspecialty clinic, right? So the other question is, well, if they just get to me, yeah, maybe there's a higher chance, but if we're looking at all comers, right? Celiac disease may be the underlying etiology. So a reasonable proportion, maybe. If you exclude other causes for short stature, so when we take out from the pool all the kids who are hypothyroid, all the kids who are anemic, all the kids who had underlying renal disorders, Fanconi's anemia, other things where they renal waste, and we take that smaller pool, so now we're looking at 80 out of the 300 kids, and we just see what the probability is they had celiac disease, then it's 20 to 30% of them have celiac disease and underlying etiology. So in my clinic, this, when I look at all these numbers, this is actually relevant to me, right? Because now they're in pediatric endocrinology. This might be relevant to Marnie Hanna. So Marnie Hanna said, well, I didn't do it because it's 1.8%. I did the thyroid, the this, the this, the this. By the time they get to me, there's lots been ruled out. So there's a significant chance this kid actually has celiac disease, right? So in our 10-year-old girl with no past medical history, no gastrointestinal symptoms, and all of the rest of this blood work is non-contributory, there is probably a reasonable study to suggest that we should do this celiac disease screen, okay?
So the CAT is based off of the best paper of all the ones you found, or is it?
Yeah, so that I think is a little bit individual. So if you find 2 randomized controlled trials in a really good big observational study, you might want to read all 3. right? So it's not a journal club in that you are dissecting only one paper. What you want to do is take the best evidence that's available in general, right? And so in there you might say, well, this study said 1 to 8%, this study said 6 to 14%, right? And you're not going to pool them because you're not doing a systematic review, but you might say they're all somewhere around, all three of these studies are positive in that we should do this screen. Somewhere between maybe 8%, and they all have really good precision, so they're all between 2 and 4% on either side of their estimated effect. So it looks like, generally speaking, 10 to 15% of kids between these three studies would have been diagnosed with celiac disease as a reason for their short stature. And then you have to decide whether or not that's worth poking the kid, 10 to 15%, right? And if, it's really, 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 really common in Manitoba, then you're like, geez, the baseline rates of 50% of our kids have it. And then on top of that, 10 to 15% that present like this also have it, I'm going to screen her for sure. But if you're like, God, nobody gets, that's the weirdest disease ever, nobody has it, and it's only 10 to 15%, maybe I'll wait, right? So all of that will play a role in how you interpret a certain paper based on your patient and your clinical question. But if you have, for example, if you're asking about transgender kids and bone mineral density, was that the one you did? No. Transgender, all right, I remember. Transgender kids and bone, so I do a transgender clinic, and parents are always asking me, well, you're not starting their cross-hormone therapy until they're 16, and kids go through puberty when they're 10, and I hear that sex hormones are really important for bone development, and my kid's gonna have a bunch of fractures when they're 60 because you're making us wait. And so, well, what is the evidence? What is the evidence that delaying pubertal onset with sex hormones at this age will actually cause a reduction in overall bone mineral density? There are two papers. One has 10 kids and it's a case series. It's just someone who's written up about their 10 kids. And then one is a somewhat cohort controlled observational trial where they wrote down the doses of what they started, exactly how long they were on the testosterone. They did routine measurements of bone mineral density by DEXA, and they did them at about the same amount of timing. Well, so I'm going to read that paper, right? That's way, so this 3 kids that James saw that he somehow managed to get published, that's not really great evidence for me, right? Because there's no internal validity to that. That's someone telling a story, which sometimes are very helpful, especially in really rare things. So I'm not knocking the fact that case reports are really important and stories are really important, because if you haven't seen it before and haven't thought of it before, nobody goes into the FDA websites, right? That's why these things are so important. Nobody goes back to say, oh my God, did you know that one kid in 2008 had pulmonary hypertension because we gave them diazoxide? No, not until someone actually publishes it in the literature does that ever come out, right? And so that's an example of where sometimes that one report is really helpful. And it might be all you get. Sometimes you're asking a question, the reason you're asking it is because it hasn't come up a lot before, right? You have a pretty good base knowledge by the time you're practicing. So if you're wondering about something, chances are there haven't been 100 randomized controlled trials about it. But I would say if you could find us, so I think the point of finding the best evidence is look for it first. Look for systematic reviews and stuff, because they're probably the best in randomized controlled trials. But if you can't find them, then take 2 or 3 of the other types of evidence and sort of pool them in your mind together to figure out what answer you get. These are websites to help you guys. So the clinical evidence-based medicine has the cat maker. Those are the top 2. Best Bets is a BMJ, I believe, publication, but it's also a website that has a whole bunch of cats that have already been done from a university, and they save them in like a data bank so that you can go and see if someone else has done it. Remembering that if they did it 10 years ago and you have the same question, it's not necessarily relevant. So I don't know how often they dump the bank and get rid of old ones. The Rochester medicine that's really good too. This says RES cats. So they have a bank of cats that are pediatric specific. So that website's quite good. And then if you listen to podcasts, Archimedes podcast, which is a BMJ podcast, does some cats as well, but just general evidence-based medicine stuff. So if you like to do that. Final thoughts. So the first thing is first, if you can't read the article, it's probably not a great article, right? So good articles are just understandable and they're in fairly plain, straightforward kind of language. Things like the New England Journal of Medicine and Science, maybe not Science, but the New England Journal of Medicine and JAMA will also have some bad articles. It will happen, okay? So don't do what I did as a resident, just look for those ones. Look for all of the evidence. And then focus on your research question, because like I said, otherwise you're gonna end up with way too many articles. Don't panic about understanding all of the stats. You're gonna get a sense of whether or not this is a reasonable thing or not. And now I've shown you what stats should be done for diagnostic therapy. If those aren't the stats, even if you don't get the extra special multiple whatever regressions and GEs that they do, if those base stats aren't there, then there's probably a problem. If there's no sample size at all, then there's probably some kind of problem, right? In terms of the basics should be there. And then just always ask yourself, does this make sense? So those are my final thoughts. I don't know where I read this, but it was quite cute. As with many interventions to prevent ill health, the effectiveness of the parachute has not been subjected to rigorous evaluation by randomized controlled trials. Advocates of EBM have criticized the adoption of interventions evaluated by observational data only, and so we believe that everyone should benefit if the most staunch protagonists of evidence-based medicine organized and participated in a randomized, placebo-controlled crossover trial of the parachute. That's it, guys. Questions? Any other questions that I didn't already answer? No? Does that make sense? Easy peasy? Okay. Those websites are really good. If you didn't write them down, I think this will be, anyway, on some kind of website so that you can then copy them down later. And there you go. Like I said, I think that the one thing that your year could maybe do is put something together to house your EVMs, which I've never actually thought of before, because we always have people do them, but I'm guessing that you'll do them